What I'd like to ensure is that ideally I would like people to leave their video cameras on and ensure that your microphone is muted when you are not speaking. Please use headphones if you're not in a private area, and if you choose to withdraw from a meeting visually, you are able to turn your video camera off. If you would like to ask a question during the meeting, please use the hand icon, which alerts me to you having a question. I can see that a number of the people present at the meeting today are in as a guest or from outside the organisation. And if you do not have a hand function, I would be grateful if you could put in the chat bar either the word comment or question. I will then bring you in, as I will do with everybody else. I will lower your hand once the question has been answered, and obviously if you mute your microphone as you join the discussion, then we will be able to hear what you have to say. Please mute again when you have finished speaking. We are not going to use the chat function for general comments other than for those purposes. If there is an item for approval, please do use the chat bar in order to put the word approve if it is an item that requires approval. I will close the meeting in the usual way, and at that point you will need to end your connection to the call. Thank you. From an apologies point of view, we don't have any apologies at this point. I am aware that Stuart will need to leave the meeting briefly for an important meeting during the meeting, and his absence is expected. He will then rejoin us, and if that occurs at a point when it is his agenda item, I will be rearranging the agenda at that point. I'd like to ask at this point if anybody has any declarations of interest, and actually Bev, would you like to come in with a comment at this point, please?
It was just to remind you, Jo, that I need to leave at 10 to 3 for about an hour.
Yep, thank you. That has been noted. Thank you. So, thank you. So, does anybody have any declarations of interest relating to agenda items this afternoon? Okay, thank you. So, what I'm going to do now is to go through the minutes of the previous meeting. I'm going to go through for accuracy first, and then for any matters arising that are not on the agenda. So I'm going to use the numbers on the meeting pack rather than the individual papers. So meeting pack starting with page 4, page 5, page 6, page 7, page 8, page 9, page 10, 11, 12 and 13. Is everybody happy that that is a true reflection of the meeting? By exception, if you wish to object to that, you may put it in the chat bar. And can anybody see any matters arising that are not on the action log? Thank you. So the action log, there are 2 elements within that are both green, and those are complete, so there are no outstanding actions from the previous meeting. The next item on the agenda is item 5, which is the Chair and Chief Exec's report. I'm going to assume that you have read the Chair and Chief Exec report. Toby, is there anything you particularly want to draw people's attention to within this report?
Thank you, Chair. And just one area, actually, Jo, I was going to touch on, if that's okay, briefly, because most of the key things come up at other points on today's agenda in terms of our big areas of focus. The one area I just wanted to draw attention to was the Virtual Wellbeing Festival, which is referenced within the report. I don't know how many people across the board will have had a chance to, during that week, have accessed or taken part or watched some of the various activities, dancing sessions, sports activities, craft sessions, and also some really inspirational speeches from a whole range of different people across sporting life and across the local community. All of the material that was used as part of that is still available to staff and to board members through the intranet. It built on work that Northamptonshire Healthcare Foundation Trusts have run over the last couple of years. And it was run this year across the whole of the system as an event for staff across all settings within health and care. And I have to say, I've had some tremendous feedback from staff from how engaged and involved they felt through that week. I had the privilege of being able to be part of the closing remarks session at the end of the week, that final event, and some great feedback coming through from things that people had heard and listened to and reflected on in terms of supporting their own health and well-being through this period, particularly given that the vast majority of our CCG staff, of course, are continuing to work from home in line with sort of guidance at the moment as well. So just wanted to draw attention to that, Chair, because it doesn't crop up elsewhere on the agenda, but a really important step we took to be part of that, supporting all of our staff. Thank you.
Thank you. And obviously, as health and care organisations, we are nothing without our staff. And so I think it's really important that we recognise them. And some of them also need a bit of a break at this point and have worked extremely hard over the last few months. So it is important to look after them. Any questions from anybody about the Chair or Chief Exec's report? OK, thank you. So we have not received any questions from members of the public from this meeting, and the action was complete from the questions from the public last time. And I'd like it noted that one of those questions related to this recording being visible, which is something that we will hopefully have achieved by the end of this meeting. So I'm delighted that we're able to give that visibility. The next item on the agenda is the item 8, which is the CCG short-term corporate objectives, which is an item for approval. So you will have received a number of slides from this point of view. I think I'm going to assume people have seen them, but I think that this is something that, so Toby and I are going to talk us through. Toby, do you want to just get started with those, and then I will pick up in a moment.
Yeah, thank you, Chair. So really important kind of culmination of the last month's worth of activity, and a big thank you from me to Sarah Stansfield in particular, who's kind of held the ring on drawing this together, but also to board members who've contributed, to our clinical leads who've contributed to this, and really importantly to staff across the organisation. Sarah's run a couple of sessions where we've had open invite sessions across the organisation for people to contribute their thoughts and ideas. And just to recap, the kind of whole purpose here was to be really clear in terms of our goals and priorities going forward over the next few months. If there's one thing the whole COVID period has shown us, is that coalescing around a common goal and a common agenda was really very powerful in terms of how we've responded. And this was about kind of where next in terms of our corporate and organisational focus. I'm not going to walk through the slides one at a time, but I will draw your attention to slide 27 in terms of the bundled rolled papers, which sets out the 5 strategic objectives that we've kind of coalesced around. And just to recap on those, that the incident response and operational support, restarting services, the really important transformation agenda moving forwards, and how we make the most of some of the opportunities around innovation and change that are in front of us at the moment. How fourthly we then continue to build what is still a new single CCG that was only formed in April of this year out of the 2 predecessor organisations. And then fifthly, the crucial work we're doing in terms of developing our overall health and care partnership on its journey from STP through into ICS status. The slides go through each of those in turn. They'll be familiar to all of us because we've contributed as we've been along through this process. So they're here very much today to do 2 things. Firstly, to approve and sign off that set of objectives together with the more detailed points that sit alongside each of the slides. And of course, today is an opportunity as well. If there are things people feel aren't adequately reflected within this or that haven't been covered across, it's here seeking approval, but that doesn't mean we shouldn't comment and contribute to that. And then secondly, the final slide in this paper, which is on 33 out of the rolled papers, sets out next steps. And again, we're seeking thoughts and hopefully support for the process which is outlined here moving forwards. In particular, how do we develop clearer indicators in terms of each of those priority areas to make sure that we can track delivery against those and make sure that we're clear on what success would look like. Secondly, around engagement with wider stakeholders, particularly with member practices and with staff, in terms of translating this deck into what it means for different parts of our system that we work with from a commissioning perspective. And then also picking up in terms of the objective setting process, both individually and with teams across the organisation. And this is the really important opportunity to get that golden thread running through from the corporate and the organisational objectives into the work that we do individually and then into our teams as well. I know, Joe, you've already picked up with clinical leads in that process over recent weeks and months, and I'm similarly working through the same process with the exec team in terms of cascading that through the organisation. And then the final point on that next step slide, recognising that this is a moment in time. This is, a period that we can see ahead of us over the coming months. and the objectives and priorities reflect that. But we will need to keep that under review, both as local circumstances change, but also as national policy progresses and evolves. And we are expecting over the next couple of weeks that there'll be further national announcements from NHS England around the next phase of progression as we come further through the COVID pandemic as well. So happy to take any questions or comments on any of the above. That's what we're looking for today in terms of approval, and then any views and thoughts on the next steps. And I'm sure between myself, Joe and Sarah, that the three of us will be happy to field comments or thoughts on any of the above. Thank you.
Thank you, Toby. And I think this very much builds on previous conversations we've had. This is entirely compatible with the strategic commissioning, which was the phrase that we were using a few months ago. It's about demonstrating meaningful outcomes for our population, making sure that we're moving in the direction. So all of this is compatible with the areas that we've worked on previously, but mindful that obviously the way that these are phrased, we need to make sure that it's tailor-made for the audience that receives those, because these will not appeal in the current format, although it's important that we do present them in this format for governing body. So Darren, please.
Thanks very much for that. Can I just ask about timelines? Just when will it be reported back to the governing body?
So, thank. Are you happy for me to comment? Yeah, sure. So I think this is something that we need to keep under regular review, and by regular I mean monthly, in terms of whether we choose to do that through a separate report, Darren, or incorporate it into the Chair and Chief Executive report. I think something that gives high-level progress against each of those areas, together with something more significant, probably at a 6-monthly point, because we're likely to see things would have changed and evolved further through that route. And if I may, Joe, I think that also in part responds to, I noticed, David, that you used the chat function just to post a question into there. I think going forward, it's helpful if people can raise a hand if you're able to, but I think the technology might not work for guests. In terms of your question, David, though, about what does short term mean? Again, what we've tried to set out here is something that we think makes sense for the next 6-month kind of period, but it is really difficult in the current climate to be able to look too far ahead in that. If we find ourselves moving back into a more significant kind of second wave position around COVID, we could be dealing and having to reprioritise within all of this. I have to say, though, I think, and I hope board colleagues will join me in reflecting that the 5 areas that we've set out here, that's going to be our agenda over the next 12, 18 months, couple of years. And it's more the detail within them that I would expect to see evolve. Thank you.
Thank you, Toby. And for those who do not have the hand function, if you just want to pop the word question in, I promise I will bring you in. Philip.
Yeah, a question to Toby, please. First of all, what is the communication strategy which will go with this strategy? And the second question is, how will we ensure that we have system alignment and coordinated planning?
Okay, thank you, and good questions as always, Philip. In terms of the communication side of things, subject to today's signing off of this set of objectives, we'll then pick up with the comms team as the next step suggests to look at tailoring the messages for different audiences. I'm well aware, and Julie Curtis and I have talked about the fact that the language in some of this slide deck is not going to land and resonate well with some of our membership and member practices. And there's something about how do we translate, what does it mean for different audiences? So there's going to be different lenses to this. What does it mean from a staff perspective? And some of our staff will actually be looking for more detail and more technical kind of commentary around parts of this. What does it mean for our member practices? And then what does it mean for some of our other partners across the system? And I think, and I can see you nodding a bit there, Philip, when I was referencing parts of that, I think it's really important that we work with our board GPs and yourselves as locality leads, with Chris, with Darren, with Amar, in order to be able to tailor that in a way that we can then usefully take it into different settings, including places like locality forums.
Thank you. Sarah.
Thanks, Joe. It was just to add in terms of, it was actually to Darren's question originally in terms of the piece about moving forwards. We're working also, Darren, through making sure that these objectives start to be built into all of our board papers. So in terms of through the cover sheets, through the reporting. So there will be the ability, obviously, to report at each period on the objectives themselves. but you should also be able to start to see how all the pieces of work tie through individually as we start to put those through the front sheets. And we haven't got them to this meeting, but we have started to work on that already. So you should start to see that come through as well, just to add.
Thank you. I think that's particularly helpful, and I'm sure we will enjoy tracking those through. Andrew.
3 quick points. I think it looks really good. I'm absolutely encouraged that it's down to 5 simple things. Secondly, don't overdo the metrics. I know we're going to be spending a lot of time looking for KPIs, but the key of KPIs for me is key. So that don't put in masses and masses and masses, just actually focus on the most important ones. And then just to re-emphasize the embed at every opportunity. So that communication strategy is really critical. There's quite a lot of research that says strategically you need to be saying these things about 7 times before they stick. The test for me is to be able to ask anybody in the organisation what objectives they're working on and have alignment at every conversation that we have. So that would be a good test for me. But I think it's a good progress, and it feels a good place to be to build for the future. So I celebrate the good work done. Thank you.
Toby.
Thank you. Just to Andrew's point about, again, the messaging and the communications on this, subject, again, to approval today. Sarah will be running tomorrow as part of our staff briefing session, which we do through Teams online, a walkthrough of all of this with all of our staff. And as you'll have seen from the 4th objective area around one team and that one team approach, regardless of whether people are employed by the CCG, by NEL CSU, or by Arden and Gem Commissioning Support Unit, we have them all together on that staff briefing session now. So I'll expect tomorrow to have anywhere upwards of 100, 120 people dialed into that call, and a really important opportunity just to start off. That's absolutely not the end, but just to start that conversation straight on the back of today's session here in governing body. Thank you.
Thank you. Are there any other comments or questions on this item? Okay. So thank you everybody for the conversation. I think those points are well made and noted. This is an item for approval. So what I would ask is that if you do approve, Andrew has already got there ahead of time. Well done, gold star. So if you do approve, if you could put that in the chat box, that would be much appreciated. Okay, thank you. So we have a quorate vote there, so that item is approved. Thank you. The next item on the agenda is the system COVID-19 report, including the reset and restoration. So we're going to move on with this item. Obviously, we have read this report. I'm going to make that assumption. Lucy, did you want to start with this one?
So the paper was primarily compiled by Sarah as I was on leave last week. So does Sarah want to start? And I'm happy to answer any questions if there's anything specific.
Perfect. So Sarah, start. Lucy will join us as required. So Sarah, please.
Thanks, Jo. So yeah, this is a summary of the current incident response and a very high level summary of the reset and restoration work as we've been bringing through for a couple of months now. Really, the beginning of the paper just reminds governing body that the NHS in England remains in a level 4 incident. So there's a lot of focus at the moment in terms of reset, restoration and standing services back up. But I think just important for us to remember that we are still in a significant incident, and therefore incident response continues through the background of everything we're still doing at the moment. We've just covered in terms of what is now available to us in terms of Pillar 2 testing data, a quick summary of the local outbreak prevention and control plan, and that was also published on the 30th of June. And then just a couple of notes in terms of reset and restoration. So the R&R group for the system continues to meet and hold the ring on reset and restoration. And the key thing I wanted to draw to governing body's attention this month was around the guidance from NHS EI from the 6th of July in terms of stepping back up key functions. So we have already done most of this, but the regulator now asking us to step back up formally a number of reporting assurance and governance mechanisms, which you can see in the paper. And I can assure you that we've either done or taken the steps to do those in the timeframes required. And then the final point is just to say we do still anticipate receiving the third phase guidance in terms of the next phase of NHS response, but we haven't had that yet. And so as soon as we do, we'll make sure that you are all cited on it. So that's a quick summary walkthrough of the report, and either I or Lucy happy to take any questions.
Lucy, is there anything else you would like to add at this point?
I mean, although I think that obviously the focus of this paper is reset and restoration, you know, Sarah emphasises the point that we still do have a significant level of community, COVID-19. So we are still having to manage the reset and restart of services whilst we have a number of ongoing outbreaks in our community settings, and also cases who still do need medical support. So it continues to be a challenge, and we are very reliant on the public playing their part in that. So, you know, it is important that people remain vigilant to COVID and services are restarting, not to forget that we still need to sort of maintain all of the basic practices to continue to try and reduce the local prevalence.
And it's probably worth mentioning that we have considerably more detail now with regard to the local prevalence, which is available on the council website, which breaks things down to postcode area. And it's very clear we have not beaten this virus at this point. So it is an area that we will be watching extremely closely, which I think is important. I've got a question from David.
Thank you. And recognise all the hard work that colleagues are doing. I suppose I'm just asking to elaborate, bearing in mind this is a public meeting, the points that Lucy has just made. And so two very specific questions. One, are we satisfied that we have the appropriate local information from the national system and that is now operating smoothly and appropriately? And secondly, there has been public discussion in the press and elsewhere about the incidents that is happening in the area. And I know the public are concerned about that, but also people are getting back into normal life in different ways. Are we satisfied that the communication about the risks that still remain is reaching the right people? And what are the risks in the short term of this spike developing further? Thank you.
Thank you. Lucy, do you want to start to respond to that one?
Yep. So data is certainly flowing much more readily between the National Joint Biosecurity Centre and Public Health England offices. We still don't have the same level of data as Public Health England do, but what we're doing is managing to work much more collaboratively with them, so that as and when we identify areas that are a concern, either because they're not following the national trajectory of a continued downward progression of cases, or indeed we see spikes in positive testing rates, etc., we are able to much more readily and in a much more timely way with Public Health England, so that they can do deep dives into the data that we aren't able to access. But we are better able to ascertain where those things are happening. As you quite rightly say, Joe, we're now producing a weekly report that's available to the public that gives a middle super output area level of information. And we're providing clinicians with more detailed data again, so that they can manage the risks locally for their patients. That, I think, is helping. I think there is a question about how effective our targeted communications are, and obviously at the moment there's little guidance as to how to make those effective. People are very excited about the ability to go back to work, to go back and socialise, and I think for a lot of people it does feel like the risk is significantly reduced. But as I've said before, we don't need to look very far to recognise what can happen if we don't continue to comply. And as I said, Northamptonshire is certainly not out of the woods. We do still have a high number of outbreaks locally, which we continue to work with the employers and the settings to manage. And we've been very pleased and very pleasantly surprised, I guess is the word, about how seriously these employers do take this. And what we have found, though, is that people do forget that once they're out of a work setting where social distancing and hand washing and compliance is regularly reinforced through signage, etc., they then go back to their normal lives. And it's things like car sharing, which you will have seen some additional communication about, which actually people forget that they have to maintain that social distancing and that discipline outside of the workplace as well. So we're working very well with our local employers and our local high risk settings, but we do need to make sure that those communications are targeted and effective. And we're working again with the Insights team at Public Health England to look at the learning from Leicester City, so that we can make sure that we do that in the most effective way locally as well.
I think, Lucy, that transparency and that sort of detail is really helpful, and it does build confidence. I know this is not for this meeting, but I cannot for the life of me, from the public interest, understand why there is the problem about cooperation between the national system and local systems, local directors of public health. I'm not asking people to comment on that, but from a public position, it seems it's sensible that there should be the closest possible working. And I'd want to make that that view as strongly articulated as possible. I don't know whether the board is in a position to endorse that, but it's probably not fair to ask people. But from a public view, the tensions between the national and local is ridiculous, and the closest liaison with directors of public health, such as yourself, seems to me essential for managing this, and particularly for conveying messages to the public about continuing risks. And just looking one's own behaviour, it's very difficult to maintain some of these. It needs constant reinforcement. So thank you to the local teams who are doing that so effectively. From the public's point of view, let's make sure there's a total cooperation between the national systems and the local systems, so that we're able to get on top of this. Thank you very much. You can hear I feel quite strongly about it, and I think that is a public view. It is absolutely ridiculous that there is a tension. There should be the closest possible links with directors of public health, and we need to make sure that that happens, and that message needs to be conveyed to those nationally who are responsible for it. Thank you.
David, just to assure you, obviously you've, I think, been also aware of my shared frustration with some of this historically. Although not perfect, it has significantly improved, and I do want to make sure that I reiterate that. And as I'm aware, concerns do arise. Public Health England are obviously, having learnt from the Leicester City experience, making sure that we get the support we need. So yeah, not perfect, but certainly improved. So I'm much more confident that we have the ability to respond as we will need to.
And Joe, just to be fair, Lucy and I haven't discussed this for several weeks now, so that's not a joint sort of comment. That comes from me and my observations of the situation, but I'm reassured by what Lucy and other local colleagues have said. And thank you again for that local partnership, which seems to be so important and working effectively. Thank you.
Thank you. That's really helpful. And obviously all of us have a mouthpiece as well, from the point of view of making sure that we do raise public awareness. I think we all have platforms, and I think it's important that we all use those in order to better protect our population. Philip.
Yes, so mine's about patient care. There are a group of patients which we're struggling to provide care for, with the so-called post-COVID syndrome, which I see as potentially being a new service which we're going to need in the future. But also there are changes in the care pathways for our patients. And when we run into difficulty with those, it doesn't seem appropriate to use a complaints procedure to identify those. But I just wondered if the system does have in place some way of identifying the present gaps in the service, so that we have got a comprehensive, effective service, whilst not the same services we had before, but that there are not significant gaps which we can't actually access the services which patients need.
So I could probably answer that question. I think we're looking both at the COVID pathway and also the non-COVID pathways as well, for, as I understand from your question. With regard to the post-COVID pathway, there is obviously considerable national guidance. We do have a a team that is working on that in order to create multidisciplinary joined up care. So that is something that I hope we will be able to report on and actually implement fairly soon. But it obviously involves making sure that that person's both mental and physical well-being are looked after in accordance with that guidance. So that is being developed as we speak and is something we are hoping to be able to offer to our population in the very near future. With regard to the non-COVID pathways, that obviously is something that is of concern to the governing body, and we continue to monitor the situation. We continue to have the GP concern system so that where primary care practitioners are aware of difficulties with the patient pathway, that system is still in operation. And obviously within the CCG, we have fora as well, where we can make sure that any additional or new patient risks can be recognised. And so I would encourage both CCG clinicians and also our wider general practices to continue to use those mechanisms in order for us to recognise what the issues are, where patient care can be improved and where there may be issues that we need to deal with. And we will do that together as a system with our partners within the system. Mitten, do you want to come in there?
Yeah, firstly, thank you, Sarah and Lucy, for the report. I just want to draw attention to page 39, specifically on the vulnerable staff piece. I think in the first phase or the first peak, if we like to call it COVID, we weren't aware of this heightened risk of BAME staff, and the evidence and reports have emerged as we've gone along. And I know risk assessments are happening in most sectors, health sector, in primary care, community care, our acute hospitals, and even broadly, hopefully, with other employers. The question is, with majority of these health and social care staff coming from this background, as they do up and down the country, if and when we faced a second peak, a lot of these staff could be potentially be shielding. So how are we monitoring some of that to ensure that safe delivery of care can continue in the middle of winter, whilst some of these staff will need to take some measures? And I'm hoping, and I think we should be doing that across the system. So apologies, because I'm not aware of what's going on, if there is somewhere, and if it's not, can we ensure that it does happen?
Thank you. I think it's a really good point. I think it falls into a number of different areas. We do have a people board that is being developed, obviously, as part of our STP, but it does fall into a number of areas. Sarah, do you want to respond to that one?
Thank you, Jo. So, Mitten, just to give you a level of assurance, risk assessments of staff are happening across the organisations, across the STP. And HR directors and the system workforce lead are currently reporting that on a weekly basis via the new NHS EI SITREP that's required. General practice and primary care included within that as well. So we have been targeted to make sure that all staff that need them have risk assessments completed by the end of the month. The first set of stats went in last Friday, and I was on leave on Monday, so I don't know what the current percentages are. But quite happy to find those out and reflect them back to governing body if that would be helpful. But in essence, really just to assure you, those processes are ongoing. They're being led by workforce leads across the system, and there is a forum and a reporting mechanism weekly to make sure that we're doing the required risk assessments for staff to just make sure that everybody's as safe as possible.
Thank you, Sarah. That's really helpful. Toby.
Thank you, Chair. 3 quick comments, if I may. I wanted to reinforce Lucy's comment around we're still very much in this and we're a long way to go before we come through this. If you look at the daily data, we test typically kind of 800 or so people a day across the county at the moment, and anywhere in the order of 20 to 25 of those are returning as positives on any one day of the week. And you only have to look a little bit to the north of us, or even to some of the other countries in Europe where they've started to see they were a bit further ahead of us coming into this, and we've started to see some of the both outbreaks and further waves coming through. So I think it's really important that whilst at the same time we rightly have the focus on restoration, and I'll turn to that in a moment, we absolutely have to recognise we've got a huge task locally in terms of messaging, in terms of supporting staff, in terms of putting appropriate arrangements in place. I am pretty reassured actually at the way that the Oversight and Engagement Board has been set up and has been run. So that's the new forum that as of last week has also now got additional powers that have been passed through at a local level to local authorities in terms of potential response to local responses to pressures here. And that's a forum which has got senior NHS input into it directly as well. So we are very much part of the conversation, which is important in terms of how we respond to anything that presents itself. But I really want us to, I know that we do as a board recognise we are absolutely still in an element of kind of incident response phase here. The second point, Joe, if I may, I wanted to make was around, notwithstanding that, the kind of restoration challenge alongside this, and it kind of ties actually to some of Philip's comments about how services have kind of changed and maybe some of the pathways for patients have changed here as well. We've got a significant level of risk within the system that has built, as it has across the country, as we've seen presentations into different settings, whether it's cancers or strokes or heart attacks, and also in terms of wait times around diagnostics, around elective treatment. I don't want to overstate that, and I'm conscious that we are in a public forum here, but it is really important we recognise that this is going to be an enormous challenge over the remainder of this year as we go through into the winter as well, to be able to both manage the first of that while starting to make headway, particularly given that we know many of our providers, particularly acute providers, are operating at lower levels of productivity because rightly infection prevention control arrangements are reducing their normal throughput and normal volume. So trying to step those things up at the same time. We have mechanisms in place, we have groups in place, we have processes to be focusing on those areas, particularly at the moment around cancer and around diagnostics. But I can't understate really that the challenge and the scale of challenge we're going to face as a system, particularly as we move out of summer into autumn, winter, and the potential for other things to step through. And then the third and final comment, Joe, just looking a little bit further ahead, Sarah mentioned earlier on that we are expecting kind of phase 3 guidance nationally over the next week or two. I'll be part tomorrow of a Teams meeting that's taking place that Simon Stevens is running with other chief execs and members of his team. So there may well be further briefing that comes through that route, which I'm able to share, obviously outside of a formal board meeting with board members, so that we all keep sighted on national expectations and asks as we go forward. Thank you.
Thank you. That's very helpful. Ange, would you like to come in at this point?
Yeah, it's a little bit late. I just wanted to pick up on Philip in terms of patient experience. Philip, I just wanted to let you know that in terms of quality and safety, one of the things our teams are going to focus in on is any trends in terms of post-COVID fatigue. We've not seen many complaints come through, but as a team, that's what we've discussed. We may see different complaints around the pathway that people are following, especially after they've had a diagnosis, and also looking at staff as well, because obviously our staff live in Northamptonshire as well. So I just wanted to give you some reassurance over that. We've not seen anything yet, but as a team we want to keep sighted on it. Also, my colleagues within KGH, NGH and NHFT, the Dons, we're also keeping sighted as well to see if we can see any trends around that, Philip. So if I do start seeing things, obviously I will report it, but that's going to be our next step in terms of quality and safety.
Yeah, if I can just comment, that's really helpful. The other thing I didn't know was that the concerns process was still working, and I'll share that obviously at the locality board meeting next week.
Okay, thank you, Philip.
And I think also just to back Ange up is that the quality team continues to receive reports of serious untoward incidents, gathers any themes, any never events, anything that may happen across the system. There is that oversight in order to understand what the experiences are that patients are going through, and those continue to be scrutinised across the system, and remedial actions put into place that are shared across organisations, and that's really important work to continue. Chris.
Thank you, Chair. Two short questions. First one is, can I be assured that we are, as a CCG, are actively communicating the latest data to local GP practices rather than hunting for the actual data? And my second question is, as the guidelines change on facial coverings for members of staff working in Francis Crick, can I be assured that front of house is appropriately dealing with visitors and staff from that aspect? Thank you.
So I'm going to bring Julie Curtis in order to answer the question, which is a conversation we've had about primary care, and then Sarah about the situation in Francis Crick. So Julie, please.
Thank you. So yes, Chris, these are conversations that we were having this morning. The information is sent, but we need to be making sure that we know where it's being sent from and to. So that's at the moment, I'm not assured that actually everybody knows where to find the information. So because it is on the council website. So we're going to try and do a link between the GP portal and the council, or at least to be able to direct people to the council website, and also be telling general practice that this is available on a weekly basis on a Friday. So that's going to be going out in the next primary care bulletin.
Thank you, that's very helpful, Julie. Sarah, do you want to comment about the situation within Francis Crick?
Sure. So the latest position in terms of the building and face covering specifically. So we continue to have arrangements in place across Francis Crick House to maintain a 2 metre distance. And therefore, in terms of, if you like, 1 metre plus and the requirement to wear face masks, we don't not applying that requirement in the building at the moment, Chris, because at this point in time, we haven't got enough people in the building that would require us to move away from the 2 metre distancing. And therefore, that's where we are at the moment. We've committed to keep those measures under review. And if at a point in the future, we either need to bring back more people and to change those distancing requirements, we will, of course, review the face covering guidance as required if we need to change those distances. But currently, the view from both myself and the infection prevention and control team, more importantly, is that that's not required.
Thank you. So any other comments on that item? Okay, thank you very much. I think that's a really helpful conversation, and is obviously something we will continue to discuss. I'm absolutely certain we will still be, this will still be a hot topic at the next governing body. Due to absence of one of our key board members, I'm now going to request your tolerance with a little bit of rearranging of the agenda. So I am going to jump to item 14, which is the quality and safeguarding report. So that can be found on page 89 of your pack, and that's an item for assurance from Ange and from Sarah. So obviously this is something where we will have read it. It fits very nicely with the conversation we've just been having about reporting incidents and the quality and safety of our patients. Ange, did you want to start with that one? Or would you like Sarah to start?
No, I'm just taking myself off mute, if you just bear with me. I'm just getting to the page. Let me just do that, okay. Okay, yeah, so obviously this report is in two parts. I've got part A and part B. I'm just going to bring you through some highlights. So obviously we have maintained our meetings that we have monthly with our main providers, KGH, NGH, NHFT and Woodlands. And we also have been having monthly meetings with St Andrews as well, with our colleagues in NHS England. So they've carried on as normal, and we also intermittently will also be doing lots of meetings via telephone and via Teams. Also, just to bring to your attention as well, is any of the learning that we have been bringing back from those meetings, we've been sharing at the clinical leaders meeting, which is really important in that aspect of that overall arching look at trends, and also looking at quality and safety across Northamptonshire. In terms of cancer, we have seen some increases in the 2 weeks wait. So just to bring to your attention that the Cancer Improvement Group has been re-established, which is really important because they're also having that helicopter view in terms of cancer services. In terms of maternity, just something really positive to raise with you in terms of a new work stream around safer practices for maternity, and also our colleagues in NGH and KGH have remained being agile in this period of COVID. And for example, NGH are working from the rugby ground in terms of having antenatals, and that's where their hub is. So they're being as imaginative as they can do to keep services as normal as possible during this time. So in a very positive spirit, I just want to talk about the joint working with the council. So again, my team is closely aligned with the council's quality and safety team. They're co-located every day in terms of sharing intelligence and responding to concerns, and also to support providers across Northamptonshire. We've also provided a lot of training for domiciliary care. That's a new thing that we've been doing, and we've actually been supporting NHS England in the new guidance around IPC training for Northamptonshire, but especially for our other colleagues in Leicestershire and Birmingham. So it's really made a difference in terms of our teams providing that training. We've also just pulled together a task force, which is really looking at quality and safety in our care homes, which begins this week, which is a real positive thing. I'm not sure if my colleagues are aware about what CQC have been doing in terms of their surveillance, in terms of their emergency framework. Instead of doing the site visits, they've done lots of surveillance via the phone. So we've had 6 of our GP practices who've had that experience already, and I believe that's been quite a positive experience, the feedback we've had. In terms of safeguarding, obviously, this has been a challenge, as I'm sure you can be aware, with the COVID period. So we have maintained vigilance. So we've had weekly meetings with our colleagues in the council. We have our monthly safeguarding board, and also we have an exception meeting for partners. That's myself, the police and the council every Thursday as well. So we've heightened up surveillance around safeguarding in terms of the work that we've been doing, but most importantly, keeping that a joint oversight with ourselves and our colleagues within the council. I'm going to stop there because that's really the highlights, and open that paper up to any questions.
So I think at this point I'm going to actually ask Sarah to finish doing the performance element of things, and then I'm going to open things for questions at that point, because I think as we've said for a very long time, it's really important that the quality and the performance are looked at together, and never more important than as we have at the moment with the pressure. So Sarah, again, we have read the paper. Is there anything you'd particularly like to mention at this point?
Thanks, Jo. No, to be honest, there's not a huge amount substantive I've got to what Andrew's already said. Just more really that you will start to see over the coming couple of months the performance report become slightly bigger again, as the performance reporting has been mandated and stepped back up. Probably the only thing I would draw to members' attention is the 52-week wait information. So we have historically had a low number of 52-week waits, and largely they are with out-of-county providers. It's still the case that they are with out-of-county providers, but we are starting to see a bigger number. So at the end of the month in report, we had 22 52-week waits. In many ways, this is almost inevitable given the RTT performance across the country. But I think just important, therefore, to highlight the quality and performance bit working together, particularly when it comes to investigation and making sure that our patients continue to be safe while they're waiting. That was really the only thing I wanted to draw to colleagues' attention from the report.
Thank you, that's very helpful, and I think it's important to recognise that behind each and every one of those 52-week wait statistics is a person with a life, and all of the experiences that they have while they're waiting for their definitive treatment, the things they may go through, and the other parts of the system that they may touch as they go through their journey. So I think it is important to know the numbers, but it's also important to recognise the patient experience that goes alongside that. Toby.
Thank you, Chair. Just picking up on that point around data and the performance side of things, you'll notice if you look at slide page 98 in the pack, that section 2 scorecard, in the last period on almost all of those trend diagrams, things either go significantly upwards or significantly downwards, depending on what the kind of indicator it is. That just shows what I was referencing earlier on in terms of the significance of the impact the last 3 months have had in particular on a whole host of different areas. Just wanted to provide some assurance to the board that in terms of data, the chief execs locally have asked the restoration group to develop an equivalent kind of data pack that we've had running and still have running for COVID for our restoration work. So we've commented a number of times in recent board meetings that there's actually been tremendous progress over the last 3 months in the way that our data and intelligence community across commissioners and providers is sharing information in a much more real-time way. The kind of data packs we now have in terms of our intelligence packs that the CSU and public health are drawing together is a quantum step forward from where we've been previously in terms of sharing of that kind of information. We want to take that same approach and need to apply it to what we're doing now around restoration, because we need to be able to get underneath what's happening in some of those graphs and trend lines, particularly those that have got more dramatic angles, so we can see what's happening in terms of waits for cancer, and we can see what's happening when it's waits for diagnostics. We can see and understand what the trajectory looks like for being able to bring those back down in line to where we want them to be and need them to be for patients and people locally. So a kind of a comment and also a bit of reassurance that the team and people are on the case across the system, working that through to get to that point of being able to do that kind of equivalent sort of intelligence pack on restoration as well. Thank you.
Absolutely, and I think the recognition that we have agreed data across the system is really, really helpful as we move together. David.
Yes, continuing the role of raising issues from the public, and thank you, Joe, for remembering individual experiences. I'd also like us to remember and to reflect on the experience of carers. I know from my own personal experience, from people I know, but there are many, many, many stories like this of some of the pressures. So, for example, a person in their late 80s as the carer for a partner in his late 80s and 90s with significant dementia, all the daycare stopped. There was minimal help with coming into the house. This person has not been able to leave the house or take any time whatsoever away from the relentless pressure of having to care for somebody with dementia and sometimes with aggressive behaviour associated with that. And that is absolutely, totally relentless. And just meeting somebody, hearing that experience, brings home the force of the emotional impact on that person who is in their late 80s. And that is typical of a lot of what's been happening. I was really reassured to hear that day centres are beginning to open. I'm not being critical of anybody in bringing this emotional feedback, because it may well be that it's difficult to know what else could have been done. But similarly, parents caring for a teenager with profound learning difficulties, acting out behaviour, including violence, have not been able to have any rest or whatever. It's even resorted to police being called to deal with some of the behaviour problems in the family home. And again, this has been relentless for 4 months. If anybody listening can hear what it is like to live in a home with that sort of constant pressure day and night 24/7. And this is the consequence which will lead us into all sorts of problems afterwards. I use those two examples because I know that they are typical. I know there are many, many people who have been that, and I'm sure many of you in this room have got clinical examples and patient experiences as the same. We have asked people to bear the most impossible task over this time, and I don't know how we can acknowledge it or thank them for doing it. Of course, that's people's committed to their families and others, but as a community we need to face up to this, and I do not hear any real acknowledgement in the public discourse about it nationally, and as you can hear from the way I'm talking about it, it leaves one feeling emotionally torn, and I know as clinicians and practitioners you all feel the same about it, because I'm not pointing figures, but as a community, how do we respond? Of course, local communities have done amazing things as well. Let's acknowledge that. But a consequence of this has been that impact on carers, and it's something that we need to remember and bear in mind. And I hope somewhere thinking about how they can get some support in future and what we do for them, because it will have taken a physical and emotional toll. I don't have a solution. I don't expect anyone to have a solution, but we need to remember that reality. Thank you very much.
Thank you, David. I think it is really important to acknowledge that this is not about just the direct consequences of COVID. This is the emotional, physical and mental health impact that are indirectly related, and those are often in many ways larger and affect a much greater section of our population. All of those people have suffered from the pandemic, and it is important that we recognise that and make sure that we do our best to look after their holistic wellbeing needs. And I think it is an important point to mention. So thank you for raising that. Chris, would you like to come in at this point?
Thank you. Yeah, this question is predominantly to Sarah. Two aspects. Do we know how our local hospitals are achieving compared to the surrounding hospitals or surrounding areas, approximately? And the second aspect is, can a version of this come to primary care so that at the point a GP sees a patient and is considering referral, this information can then be discussed at that point? Thank you.
Thanks, Chris. So the first question, in essence, in regards to benchmarking, we do have some very high level regional information, but the honest answer is at the moment, no, we don't have local benchmarking at a detailed level. Although as everybody starts to stand back up reporting over the coming month or so, that should be easier to get our hands on. And then in terms of the last question, in terms of making the information available to primary care or to GPs specifically, really happy to look at that, but would probably appreciate an offline conversation about in what format and at what level of detail that would be most useful. But really happy to make available whatever we've got that can help those conversations. Yeah.
And I think just to add back into that, that is a conversation that has already started with our primary care networks with regard to the information that they would find helpful. So I think this is a good time to raise that. So thank you for raising it, Chris. Ali.
Thank you, Chair. It's a comment and a reminder that as we restore our services, it's a fantastic opportunity to change some of the services as we work together, particularly across primary care, the acutes and the community providers, which will obviously impact on our performance. So there's a transformation and change agenda. So we're not just stepping up like for like where it's not appropriate. So I just felt it was important to re-emphasise that. Thank you, Chair.
Thank you. That's really helpful. So I can't see any other questions on that matter. So what I'm going to do is I'm going to continue with the agenda as it is at the moment, and then come back to the items that we've missed. So we're going to move straight on with the primary care report, having already touched on primary care. This is the paper that starts on 101 of your pack, and obviously contains some overview of everything that's been going on within primary care. Julie, is there anything you would particularly like to draw our attention to?
Thank you, Jo. There's just a couple of things I think I would like to bring to members' attention. So we, just so that people are aware, the additional roles up to 10 different professional roles are still available for practices and PCNs to be able to recruit to. So some of this is where I'm bringing really to the governing body about what is still being maintained by the national guidance of what's still available for our local area and nationally. We're required to develop a workforce plan by the end of August. That's just been slightly delayed, but that would be a very good barometer as to what the recruitment, what individual roles each PCN would be particularly interested in recruiting. We will be setting up, well, not will be, we have set up recruitment campaigns, working very closely with the clinical directors to be able to make sure that we, one, co-create the workforce plan and that we actually co-create the fuller, more county-wide approach to recruitment. You may remember how successful we were last year when we went out to recruit pharmacists and also the link workers. When we did this across the county, it was an extremely well supported and successful campaign. It's more important this year probably than ever because of the slippage in the time because obviously we haven't been doing any of this work from April, which we would normally have been started in February, which we did, and then we stepped it down. So we are working very closely together to be able to do these recruitment campaigns, and also, like I say, it will give us an idea as well as to which roles particular PCNs may prefer to have within their teams, which is really helpful. Just moving on, and I put more detail in the paper this time about the 3 enhanced services, so the specifications that are due to go live, that the PCNs are working on and working through now for the go live date on the 1st of October. And this is despite the fact that we've had COVID. This has not changed. These specifications and the date for introduction has not changed. Some of the care homes work, you may remember, has already been brought forward, but this will be a more targeted approach with the full specification this time. So we're working very closely again with the clinical directors within the PCNs and the practices around alignment of care homes to the practices in the PCNs. That piece of work needs to be done by the 31st of July. So we have been working very closely over the last month so that we are able to obviously hit that deadline of the 31st of July. The activities that will be required from the 1st of October include things like the weekly ward round, advanced care planning, MDTs in the care homes, established MDTs, and structured medication reviews. So it's very comprehensive, and we're working very closely with everybody, because actually at the moment this is probably one of the key major priorities that we need to be doing over the summer, so that we can get this all aligned for October. So I'll stop there and ask if there's any questions.
Thank you, Julie. That's really helpful, and it's helpful to have that level of detail, I think, for the governing body. Philip, would you like to come in at this point?
Yes, just to ask about a system-wide approach to on-the-day demand. Currently in primary care, we're seeing a big increase over the past couple of weeks for on-the-day consultations, most of which was for triaging and undertaking by phone. But usually when that happens, the next thing is for it to hit secondary care in the form of A&E departments. And I just wondered within the system whether there's any ongoing work around on-the-day demand and how that's going to be managed.
Julie, do you want to comment?
Comment on
that one?
But it's an interesting question, because it's all demand has been almost suppressed, hasn't it? Right, and now we're seeing that difference, in the fact that, well, people know that the NHS is open, which is right, and that on the day demand is part of the work that we're trying to do around the integrated urgent care offer as well, about actually aligning a lot of the urgent care or urgent response across the county, and that's definitely something that I'm working on just at the moment, and that's about aligning access to general practice services in a way that might be easier for people to be able to access it at the right time, in the right place. So that is definitely something that I'm working on just at the moment.
I wasn't quite sure if you would have the answer, but I just wanted really, I think, to highlight it as an issue which we're beginning to face and which the system is going to need to address in some way. And as I say, I think it needs to be not just you, Julie, it needs to be a system-wide approach to it, doesn't it?
Yes,
particularly with your question, Philip, I think it's important to recognise that general practice has been open, but as you've said, it has become much busier, but general practice has been open throughout the pandemic, people have chosen not to consult for a whole variety of reasons, and many of those reasons people are now presenting, and obviously with many of the referrals within the system, those start with general practice. So I think that increase in activity is important to recognise at this point. There are places in the country that have captured that in a variety of different ways, but it is important to recognise where that activity is taking place within the system and where patients are choosing to seek their healthcare from, in addition to organisations such as 111. So I think that's important. Andrew.
Yeah, just 2 quick points on that. One is, one of the conversations we were having in primary care committee was around, there's a massive change in primary care and great efforts from the team to get digitisation, virtual meetings in place, etc. We've got to ensure we don't just assume that patients will automatically default to this. They will have done in the crisis, but actually their default position will be to go to the physical. And so we've got to make sure that we align the messaging to the activity and not slip back. And second is, just picking up on David's point earlier, is we also need to make sure that the care homes are supported from primary care, because there was this sort of feeling of remoteness for lots of the care homes. So we need to ensure that the measures that have been put in place now support that relationship to be built up again between care homes and primary care, because that will be their first line of sight and first line of contact for care homes who've been stretched quite considerably.
Thank you. I think that's an important point. Toby.
Thanks, Joe. Different tack. I'm just pleased to note that the estates work is being stepped back up again now. I think it's right and understandable that that was paused whilst we went through the kind of initial peak in terms of COVID response, but pleased to see that's coming back into action. And just to link into that, if I may, Chair, the Health and Care Partnership is also stepping back up the system-wide estates work, which of course the primary care and community estate is so important, particularly in terms of the work around PCNs and hubs within all of that. And that work is going to be picked up and led from an exec point of view by Polly from Grimmett from KGH, who the acutes have kindly offered to put into that lead role, working with all of us. And that will also sit closely alongside the work that the HIP2 programme, in terms of the national funding around the acute estate, particularly Kettering, but not exclusively, is also going to be able to support. So from a wider governing body perspective, I know Simon Weldon and Alan Burns are keen to come out of a conversation with us in informal space in some of our thinking time session around that wider acute configuration linked to estate and HIP2. But I think there is a connection here that we need to be making back into what's happening in terms of primary and community facilities, which is one of the reasons I'm so pleased to see that back up. And also just worth noting, I'm from a personal point of view, are starting to re-engage as well with a number of practices on estate-related issues. I've got a site visit tomorrow with one of our practices to follow through on some of those conversations. So welcome seeing that back on the list again, Julie. Thank you.
Thank you. So Julie and then Mitten.
Thank you. I just wanted to respond to that point that Toby's just made. So I'm very keen also that it's not just the estates, but we do the estates and the digital agendas. The strategies need to come together now, and being simply because we might be able to use estate in a different way because we can now use digital technologies in a different way. So I'm really keen, and at the moment we are developing our digital strategy, and we'll be developing our estates and premises prioritisation as we go forward. So I think bringing the two together is really important right now. So thank you.
And noting Lucy's comment and agreement with Julie, last comment from Mitten, please.
Yeah, it's more a question and a comment. I think there's a couple of things, Julie, around the additional roles piece, which is obviously part of the national PCN and how general practice responds forward. And then links to what I think Philip was saying earlier, that if we look at the whole additional roles piece that we're going to do in the county and do that across the county, which is excellent, how do we link that to the workforce strategy that Sanjay started sharing, such that we bring the right level of additional workforce in the county, not just choose from the menu that NHS England have given, because there's a flexibility piece built there to say if locally we need something different, we can do that locally. And then as a direct output of that, how does that resolve some of the same day pressure that primary care will face, not just during COVID, but when we come out of it. So are we triangulating, is the question, those three areas? And if we are, how are we communicating to some of our PCNs such that they don't just choose from that menu to say, oh, we must choose a podiatrist, even though we don't have much podiatry need, and a care coordinator, because that's what the national document tells us to do.
Julie, you may not be able to answer that enormous question as briefly as I might need you to. So if you give us an overview, that would be great.
So just to provide assurance, that triangulation is happening. We are making sure that we do not want to be taking and destabilising other organisations because of the fact that those are the staff that need to come and work in the PCN. So that's one. And secondly, there is only a limited amount of flexibility that we can apply to this. And any flexibility that we can apply, we do. And we just need to make sure that that when we do the workforce plan, right, by the end of August, I think that will absolutely include that triangulation of what staff each PCN wants, prefers, based on their need. As you say, you don't have to have one of each of those. It is based very much on what the PCNs need, and we work really closely with them. And you know, we've got a workforce we have people that work on workforce that are working very closely with them. So hopefully that just provides a bit of assurance.
And I'm absolutely certain this will come to many governing bodies because it's such a rich and varied area of work. This is something we will continue to hear about. So I'm delighted to hear about it today. So we're going to go back now from an agenda point of view, back to item 10. We have Stuart with us again. And so we have a presentation now on the risk management report.
Thank you, Jo. And apologies again for just having to pop out of the meeting. So I've got some slides and as a way of an update. So if you could go to the introduction slide, Neil, thank you. First of all, this was probably a reminder that we had a discussion both at the Audit and Risk Committee and Governing Body, which links back to the obviously the previous paper presented by yourself, Jo, and Toby earlier about the corporate objectives. Then what was asked, once we sort of sought that, what would be the strategic risks and how we would manage them, noting the good work that's been done about real-time working and real-time activity and how we would manage risks at real time. We also have ownership of these risks, not only as an individual sort of directors or as a team. So what we need to remember is this was only the first point, so that the corporate management team, CMT, was then asked to go away and work on them, and it would only be the first point to bring back to the governing body in the deadline of August. Noting we would then need to link them to other bits of the system and other bits of the CCGs, both clinical, other partner organisations, so we have that full triangulation. And obviously we have, the third point says emerging corporate objectives. We now have approved corporate objectives from the earlier slide, so we can now sort of finalise that. So if you could go to the next slide. So this gives you the sort of high level timeline that the CMT has been going through discussing it. I can confirm that we've been having some extended meetings to talk about this, and I can let my other colleagues and directors and Toby come in if they wish to at some point. But we've started working on that, and when we bring the risks in August to the governing body as our view of how they link together, we will identify, obviously a director will highlight how they link directly to the corporate objectives, which will also go back to what Sarah correctly highlighted, the front sheet of the papers as well. So it won't just be the objective, but any risks or things will be there as well. So we can see that. So this work is ongoing. We're going to have quite a bit of stuff. I'll just do the next slide, please, Neil. And that goes back to the 5 objectives. I won't go through them again, but they will be linked to those. So on to the next slide, please, Neil. So the next steps are, we are talking about this. We will look to finish this over, in essence, the next few weeks. Noting we've already had a discussion about what we think initially as a governing body what the high levels risks might be, which are listed there. I won't go through each of them, because we've been through them again and previously. So next slide, please, Neil. So this then sort of confirms, to give assurance both to the governing body, and I went through these slides even quicker at the Audit and Risk Committee this morning, which had quite a good debate about the progress we've made, the ongoing work, the fact we will bring them back to the governing body in August, and there were some good suggestions of what else they would like to see when we bring it back from the Audit and Risk Committee this morning, which anybody at the Audit and Risk Committee would also wish to comment. I'm sure they can in a minute. And I'll stop at that point, Chair, for any questions.
Thank you. Worth waiting for. Any comments or questions? Richard.
Thank you, Chair. Yes, as referred to, we did have a good debate about the slides and the risks at the Audit and Risk Committee this morning, and a number of items were raised, some of which Stuart's already referred to, actually, around how the committee members were interested to see a clear linkage between the risks and the short-term objectives that we talked about earlier. A clear assignment of the risks to corporate leaders to see who was going to take responsibility for them, and then there was some further comments also around clinical engagement and around how we link into to clinical impact assessments. And I know, Joe, that you're already looking at. It was mentioned this morning that you're already looking at clinical risk and how that feeds into here. So it would be useful to see how that develops too in the next draft of this. And then also a comment around how this links in with the GBAF and the risk appetite work as well. So I think we had a really good debate around it at Audit and Risk Committee this morning. It was a recognition that it's a work in progress and it needs further development, and that we're looking forward to the next iteration in August, and when we can have a look in a little bit more detail again.
Thank you, Richard. That's helpful. Bev, did you want to come in there?
I think Richard and I probably pressed raise your hand at the same time, and he's covered the things I was going to say. So no, we had a really good debate. I think we just want to see that further alignment of all the different parts of the process, really, as the next iteration comes through.
Thank you. That's helpful. I didn't want to leave you out. Toby.
Thanks, Chair. Just a thought on how this work progresses over the next couple of weeks. And sorry, Stuart, we haven't rehearsed this, but don't feel too anxious about what I'm about to say. I think one of the strengths of the corporate objective work and the priorities work that's been done over the last month is how wide an engagement there has been and involvement in that. And I think the material that we signed off a few moments ago is richer because of the process we've been through with clinicians, with lay members and with staff. And I think there's something for me, Stuart, about how we build that into what we do from a risk perspective, because of course all of our views on risk and our individual perspectives will depend on the kind of lens that we look at the system through and the role of the commissioning group through as well. And I think we'd end up with a richer understanding of the risks that we face on a number of different levels if we can make sure in the next few weeks we find a way to reach out to those respective groups that are all involved in different aspects of CCG work. So I'm thinking, Joe, for example, you're linked in with our GP locality leads on the board. I know that you and I also have a session with lay members informally on a fairly frequent basis now. And so if we can perhaps use some of those opportunities informally to just tease out with people what are the kind of key strategic risks that are at the forefront of their minds, I think we'll end up with a better, richer product as a result. Thank you.
Absolutely, and we very much welcome that approach of extensive engagement. I think it does help to bring everybody's views into the conversation. Philip.
Yes, I don't envy your job at the moment, Stuart. For those of us who can remember when we had 18-month waits for cataract surgery and the huge investment it took to get the waiting times back down again, together with the pay rises which are going to have to be absorbed. It's a mammoth task. And I just wondered if you'd thought about what sort of guidance your team will be able to give to the governing body and to the executive officers and the decision makers within the CCG around prioritisation of future investment and how those decisions will be taken and shared.
Stuart, do you want to comment on that?
Yeah, that's quite a good question again, Philip, and it is a discussion that we're having not just within the CC but across the system. For example, discussions are ongoing how the financial regime is going to change, which will be quite difficult, and the way COVID is funded is going to be different. But the discussion would be, so it's not the chief finance officers to make the decision, but more to guide and give the guidance, as you suggest, with then getting more clinical prioritization. So I must probably put somebody back to the clinician saying, how would you prioritize this? But this is the guidance you've got to work with. This is the rules you've got to work with. And this is the envelope you've got to work with. How do we then get, going back to the risks, a wide selection of people involved so we can get the whole system engaged as best on getting the right priorities is the way I would be looking at it. But fully accept it will be my job to help guide that, to make sure that I put the right information in front of everybody.
And I think there is something here very much about the clinicians and the managerial teams across the whole system working together. This is not about one group of people who make the decisions. This is system decisions, and some of those conversations have already started within the Health and Care Partnership, and it is moving us towards together. But we're also looking at clinical risk as a system as well, and that isn't something that we've done before. It is particularly important in light of the situation that we find ourselves in. So it does require more than one discipline in order to inform the difficult decisions that we're going to need to make. Any other comments on the risk management report? Thank you. So the next item that we're going to move on to is on page 41 of your pack. For those of you who are still using paper, you'll need to scroll back a wee bit. And that is to do with the CCG governance arrangements, which is another Stuart item. Stuart, over to you.
Thank you, Chair. I'll assume the paper is read. If I was to give the highlights, this is about now stepping back up the committees of the CCG, so there'll be more business as usual, and linking into, again, linking more people into what's happening, which is obviously a good thing, plus reinstating, in essence, the financial instructions and scheme of delegation for the organisation, but noting if there was a wave 2 or something to hit, that gives delegation to myself and Toby to reinstate the limits, but only under the premise if there's a big hit for COVID-2 second wave. And it must probably, at this point, again, we had this discussion at the Ordinary Risk Committee. Part of that regime was that I had to report monthly to the Ordinary Risk Committee about the spend we've done, which we've done each month. We've also had internal audit look at that, the governance that we've gone through in the process, which they completed and submitted the report to the Ordinary Risk Committee. That gave us a good report, full assurance on that we followed all the financial regimes, and as it happens, we haven't had to use that unlimited. Everything fell in. When we needed to do a single tender waiver, it was done. Was it within the authorising limits before this? Yes, it was. So everything has been done, and we had independent auditors to do that for us, and that report went and gave us a complete clean bill of health and full assurance. I'm not going into most probably bit into the finance report later, but we've also had the first 3 months now totally funded by the national team, everything funded. So everything was classed as reasonable as far as the CCG has committed spend. So I'll stop at that point.
Thank you. That's helpful. Any comments on the governance arrangements? Toby.
Thank you, Chair. I think the paper's right. I think we need to step back up again some of our other arrangements that we've stood down. I think in doing so, we need to be mindful as well. I referenced earlier on the Health and Care Partnership Board meeting that took place on Thursday last week. That's made some quite big steps forwards in terms of agreeing to scope out during August a small number of collective committees across the system, so covering finance, covering transformation, covering engagement and involvement, and also covering quality, safety and performance. And that's a big step. It's something we're going to need to come back to in terms of some of our thinking time session. But there's something for me about how those system-wide committees that start to look across the whole of the county with commissioners and providers align with the arrangements we've got in place from a CCG perspective. None of that's to take away from the fact I think it's totally the right thing to do to start re-establishing these, but particularly given some of them have actually not met in that format previously, thinking particularly about strategy and planning. We obviously moved from 2 predecessor organisations into new organisation on the 1st of April, precisely at the same point that we stood down some of those existing arrangements. So I think it'd be helpful for the exec leads, together with the chairs of each of those groups, particularly I'm thinking strategy and planning, to give some serious, careful thought, assuming we support this step today, about how that meeting on the 4th of August focuses, not least because the national kind of context, as Stuart's just been reflecting around planning and strategy, is so different at the moment to where we've been previously. So I think the time's right. I think we can make them really purposeful. They might not necessarily be covering in the first instance the totality of their normal remit because of where we are from a national perspective, and we should think carefully about how that links with the system committees that are now being scoped up as well. Thank you.
Thank you, that's helpful. David.
Yes, it's a repeat of something that's been said before. But clearly there's got to be a lot of energy and a lot of drive and a lot of pressure to get into these things, particularly with over the next few months. But at the moment, we haven't really got in place an engagement strategy clearly defined, and how we involve and consult and bring people in. As far as the public is concerned, some very, very big changes being explored and discussed. This has been discussed at the Health and Care Partnership. The risk is that organisations, because of the pressures on them, will rush ahead with all sorts of plans without integrating their thinking, and involving the public in that in some way is going to be really important. I know people are aware of it. I know people are sensitive to it. But a month can go by and we haven't got this in place, and that we can suddenly find that plans are rushing ahead and the public haven't been properly involved and they kick back. So it's actually not sensible to leave it. So I know there are discussions in place. I'm just putting the marker down again. Thank you.
Important point and very much welcomed. Toby.
Just a response, David. Last week's Health and Care Partnership Board, sorry, I've referenced it several times already today. I know you weren't able to be with us, but one of your colleagues from HealthWatch was. There was a specific ask there for you and HealthWatch to work with Bev, with Tansy, the sort of previous chair of the Stakeholder Collaborative Forum, and with Dion, who leads that engagement and involvement work for the partnership during the course of August, in order to shape up a proposal about how we put in place some different arrangements going forward for NHCP as a partnership, and also that of course draws us into that. So I hope that's something you're up for working with us on, but quite a number of us feel there's an opportunity to do something here significantly more ambitious than perhaps where we were when we went into this period, and we're keen not to just automatically step up the arrangements we had 4 months ago, but to take the opportunity to do something a bit different on that front. So any thoughts and contributions will be really welcome on that front.
Yeah, my colleague Susan Hills was there as I wasn't able to be there. Yes, that's really positive and helpful, and it's part of the creative new approach which we all need to develop, and very much appreciate the approach that's been taken by colleagues. Thank you.
Thank you. Any other comments on that item? Okay, so we're going to move on to item 12, which is the finance report, which is on page 69. This is another Stuart item, so we're very grateful to have you back because we've missed you. This is
sorry, Jo, can I interrupt?
Yes.
We just need to approve that last item.
Thank you very much. That's fine. So the CCG governance arrangements, as we have done previously, I've not heard any objection to those. I've heard some really helpful comments. So if people are able to type the word approve, if they approve in the chat bar, that will be much appreciated. And I will wait until we have sufficient numbers for that to be quorate. Perfect, thank you. And those of you with Apple Watches will find that your wrist buzzes rather a lot at this point if you have connected your Teams to your watch. Thank you. So much appreciated. Thank you for the reminder, Sarah. So we're going to move on to the finance report. Obviously, this contains considerable amounts of detail. This is a report for assurance. Are there any particular areas, Stuart, that you would like to draw our attention to?
I think that the only thing I would highlight, at the time of writing, we were waiting for some guidance past the end of July. What has happened since the time of writing this report? They have rolled forward the current guidance for the minimum of August and possibly, they're saying, September, while national discussions go on with the Treasury of how that will work going forward. And obviously, as I previously said, the first 3 months of COVID has now been 100% reimbursed to the CCG of our claims we've put in. And everything else is in the report.
Thank you.
Take any questions?
Any questions or comments? Toby.
Right, me again. I just wanted to put on record and thank Stuart and the team for what they've done on the first few months of the year position, because it'd be easy to just think that was a pretty straightforward thing, and that will be universally the case with all organisations across the country in terms of that full reimbursement of the ask that went through. I think the fact that we've landed where we have is because of the robustness of the approach that was taken in terms of making sure that what was supported was in line with national expectations, but also the relationships and the communication between Stuart, the team, and the regional colleagues. And it's worth noting that there are large numbers in there that the CCG has incurred expenditure against over the last 3 months, particularly in areas that would not normally be our area of business or commissioning spend. Stuart will recall the numbers better than I do, but if you look at the kind of spend on areas like personal protective equipment, PPE, we're into the couple of millions on that in terms of the amount the CCG has spent that would not normally go anywhere near our books on this stuff. But we've been able to provide mutual support and aid across the whole of the system, including to the care sector and local authorities. And we're continuing to do that as well. So we are continuing to incur additional expenditure. We're supporting people in that area who have personal health budgets, for example, and some of their carers and other support staff. So just a thank you for me really to Stuart to recognise. Stuart can go over things very quickly at times, which is appropriate and helpful on the timing front, but it sometimes misses the amount of work that sat behind that to make sure that we've been kept corporately safe in terms of our financial position on that. So thank you.
Thank you. Any other comments on this item? Thank you. So as I say, it is a detailed paper. I think it's answered most of the questions and very much appreciated. Moving on to the next item, that's item 13, which is the contracting and procurement report. Over to you, Sarah.
Thanks, Joe. So I'll take the report as read. Similar to Stuart, things to pull out, that the same financial guidance that has been rolled forward applies to the contracting guidance as well. So at this point in time, the guidance for contracts is still the same as it was previously, and we expect that to be rolled forward. We continue, from an activity point of view, if you look at the first couple of pages of the report, particularly in our acute sector, continue to see activity at significant volumes below where we had originally perhaps planned it to be. And that will be an inevitable corollary of the things we've already talked about, particularly in terms of performance. But just so colleagues have noted that, we are working towards a view of activity that we can brief you on in terms of the mental health sector as well for next month. So hopefully this report will iterate itself over the coming month. And then the last thing, just to a couple of comments on the procurement agenda. So colleagues will have noticed we have stepped now back up some procurement activity owing to some more resource being available to us. So a couple of procurements started and a couple that were paused, we have now picked back up and moved back into mobilisation phases. And so just to note the management of those going forward and the intention to get to a different type of procurement reporting in terms of dashboards around contract expiry risk and a more proactive approach to contract renewal for the CCG as we move forward out of the current circumstances. I'm happy to take any questions.
Thank you. That's very helpful, and in particular on the procurement report, seeing that we are going to be addressing the well-being of children, as David has mentioned previously. All sections of the population have struggled during the COVID pandemic, and children's well-being is very much another one of those areas that's important that we do not forget as we emerge from the particular phase we're in and enter the next phase. Any other comments? Well, I think that paper has obviously answered all of the questions. Clearly a well-written paper, and very much appreciated. So thank you for that. And that's obviously been presented to us from an assurance point of view. So from the point of view of the key messages from the meeting, I have 5 key messages. I think the one is that we've approved the CCG short-term corporate objectives and look forward to sharing them with staff members and partners. We recognise the ongoing efforts to continue to combat COVID-19 while resetting and transforming services. And the governing body recognises the important and recognition of quality safeguarding and safety issues across our system. The 4th item is that we recognise the importance of shared and understood system data flows. And the final item is that we welcome the change in the CCG governance and recognise this in the context of the system changes and a genuine desire to work with patients and partners as we plan for the future. So thank you for everybody, and thank you for adhering to the meeting etiquette, is much appreciated. At this point, I'm going to declare this meeting closed. And Sarah, if you could stop recording, that would be much appreciated. Thank you.